So let's go on, and for now we'll have a number of talks on the different registries. So from every region or country there will be someone talking on this, and I'd like to start with Jan Johansson, who will show us the things that are really important in Sweden and the results from Sweden. Go ahead, Jan.
Thanks. Thanks for giving me the opportunity to share with you some experience from our Swedish esophageal and gastric cancer registry that has been up and running since 2006. And 2007, we went fully web-based. Oh, sorry. The aim of our registry is to provide knowledge about how care and nursing works in our country and how to improve it, of course, and also to facilitate research. And we also have the aim to include all patients with esophageal or gastric adenocarcinomas in the registry, with or without treatment. And we also include patients with squamous cells carcinoma of the esophagus. Unfortunately, in Sweden, registration is optional, but it's strongly recommended by the authorities. And this is very much in contrary to what it's in other countries. And we've tried to adapt our registry to the Clavian-Dindo classification of complications. We have, as Bill mentioned, the ECCG group, but also the GCCG group has guidelines, and we've tried to adapt to those. And we also have started a Nordic esophageal and gastric cancer group where we try to focus on a minimal data set for our Nordic countries. Cancer registries in Sweden, they are mainly developed by healthcare professionals, and it's traditionally been driven by surgeons. But we have also included patients, epidemiologists, statisticians, and app developers for developing a good quality registry. And the registry is mainly publicly financed, and most of the surveys that I will go over with you, they are filled out by doctors and nurses, in some cases by secretaries. To be able to do this, we have 6 regional cancer centers in Sweden who provide us with the development of the technical platform that is common for all cancer registers in Sweden. We also have a support organization to end users who perform some monitoring of the incoming surveys and do some preliminary validation of the data. And we have a continuous validation program that will start off the spring 2022 after 2 previous validations we already have done. And how do we provide our users with feedback? Well, we have the more intellectual part with annual reports, and we've had that since 2007. We usually try to focus on the last year's results with some comparisons back in time, and they can be found on the web. The most interesting part of the user feedback, I think, is our workhorse for the clinicians. It's open NREV, it's called. It's based on the Shiny package from R, the statistical program R. It's a free usable tool where you can present interactive details and do your own data mining on selected topics that we've prepared. It's a really good one, actually. Then we have full access to our own data. We can get customized output for clinical use, and we've also done some clinical research and published 21 papers as of now. As I mentioned, we have several different surveys. We have one diagnostic workup survey, which has a coverage rate of 95%. We have several therapeutic surveys, one surgical and some oncological surveys with different coverage rates, follow-up surveys 3 months after surgery and 1 year after oncology treatments. And we also have, as Pernilla Lagergren probably will tell you, quality of life and health economics follow-up 1 year after diagnosis, irrespective of treatment. And the coverage rate for that is unfortunately very low. Just some brief results from our registry. As a result of our national guidelines, we have fewer and fewer hospitals performing esophageal and gastric cancer surgery. We have improved our results when it comes to lymph node dissection, but not regarding anastomotic leakage. And this is probably reflecting the introduction of minimally invasive surgery, as Bill told us. Some more outcomes. We have about 30% resection rates in our country. We do have complications, and as we saw on previous slides, we have more complications after esophageal than after gastric cancer surgery. We have 15% anastomotic leaks from 2007 till 2020. We do have severe complications, and we do have a 90-day mortality rate that's approximately equal between esophageal and gastric cancer surgery of 6 and 5%. So what have we learned? We've improved our registration, our neoadjuvant therapies in esophageal and GE junction cancers, and as well as in gastric cancer surgery. We have improved the results for RO resections regarding esophageal cancer surgery. 30-day mortality is approximately 2%, unchanged over the years for esophageal cancer surgery, but we have improved for gastric cancer surgery. And when it comes to long-term survival, we have unexplained better survival actually for females than for males in esophageal cancer surgery, but it's the same level, approximately 37% for gastric cancer surgery. Yeah, and this was what 5 minutes will give me to the ability to present to you. So this is my final slide. Thanks.
Thank you very much, Jan. Really great to see those results. There's little time, we already said it. I tried to show a timer to the speaker when you're at the end of 5 minutes, but we'll go on to Nick Maynard now, and he'll show us the results from England and Wales. Go ahead, Nick.
Thank you, Mark. So the National Esophagogastric Cancer Audit is commissioned by the Healthcare and Quality Improvement Programme, which is an independent body, but it's funded by NHS England. And that's part of a broad national clinical audit programme, which includes about 10 cancers and many other diseases as well. It is mandated for NHS trusts to collect data, and the data is collected by variously different individuals in trusts, often very poorly resourced, I should add, and then uploaded centrally. We collect data on all columnar high-grade dysplasia and all epithelial esophagogastric cancers, describing the route to diagnosis and staging, treatment plans, waiting times for treatment, curative treatment both surgically and oncologically, and palliative care. It's carried out by the Clinical Effectiveness Units in the Royal College of Surgeons in conjunction with NHS Digital, the College of Radiologists, the British Society of Gastroenterology, and of course, AUGES. As you can see on the right, we publish a report every year. There are various outlets for giving the results out, but possibly the most commonly looked at is the clinical outcomes publication, which you can see in the top left-hand corner. You provide a forest plot for all the units carrying out esophagogastric resections, and you can see where your trust is. For example, the green dot there is our trust, and that tells you the number of operations done in that time period. plotted against the mortality rate, and you can look at 30-day or 90-day mortality rate. And we have an outlier policy. So if you are an outlier, there is a system in process which we can then look in to see if we can improve the data, and then if they need any help in improving their outcomes. You can also look down at individual surgeons and look at their activity levels, the number of resections they're doing, their mortality rates, their length of stay. And in the last 6 months or so, we've introduced the composite score, which looks at a much more holistic approach of the whole service each hospital provides, looking at 3 domains: the quality of the audit participation, how good their case ascertainment is, the staging, the investigations, and then the surgical outcomes, looking at mortality rates and various pathological data that we collect on margin positivity and lymph node yields. And that gives a broad outline of how good the totality of their service is. There are many different ways of feeding back to institutions. There is, as I've mentioned already, the annual report we publish, and this is published on the NOGCA website, on the Augis website, on the HQIP website. NHS Digital release it as well, and it's also stored as part of the data.gov UK, which is the main repository for all data related to healthcare. Each institution is also given an annual report slide set in the form of a PowerPoint presentation with all their data on it, so they can present it at local audit meetings. They're all given the clinical outcome report and those graphs, which I just showed you. We now give them a quarterly report, obviously 4 times a year, and this is an example of what each trust will get. And you can see in various different domains how you perform against the national average in whatever domain you choose to look at. As Bill mentioned, there's an annual patient report as well, and we have a really strong patient group who advise us on that. It's all on the website, and there are, of course, multiple conference participations. To ensure it is clearly transparent, and there is a sort of fairly robust system of checking all the data and audit, and it's linked to various information sources. So each trust puts in their own data, but it's linked to the hospital episode statistics for England and patient episode database for Wales, the Office of National Statistics, which has accurate mortality data, so we can cross-reference to that, the radiotherapy database, the chemotherapy database, the intensive care database. All preliminary data is sent back to institutions for checking and correcting, and we always report on data quality in the report and make recommendations to improve data collection. My final slide. The first audit started in 2008 and finished in 2012, and the second audit, which we're still in, which is much more comprehensive, started in 2013. And we've shown a significant reduction in mortality between the 2 audits. The lower graphs look at some of the outcomes in the current audit, showing a significant reduction, improvement in survival, improvement in pathological data such as margins and lymph node yields, and a reduction in length of stay. Thank you very much indeed.
Thank you, Nick. Very nice overview, very clear results. We'll discuss them later. I'll just go on to Spain now. Manuel Pera, you're going to show us the results from Spain. Go ahead.
Yes, thank you, Mark. Well, I'm going to present the information about our registry. This is a very young registry. The Spanish EURECCA esophagogastric cancer registry was launched in 2013, originally linked to the EURECCA Upper GI network in Europe. This is a population-based registry aiming to improve outcomes by measuring quality of care, giving benchmark feedback to surgeons, and also stimulating improvement initiatives. Since its foundation, this project was led by surgeons, although there is a scientific committee comprising different medical professionals such as oncologists, pathologists, and epidemiologists. Eligibility is limited to those regions in which all their public hospitals are committed to entering all cases of esophageal and gastric cancer resection. Structural funding is achieved through research grant application, and there is, at present, there is no support from the government or surgical societies. This is we have an online registry system where all hospitals include cases with intent of resection. We have 96 variables covering all stages of the clinical pathway and short and long-term outcomes and quality measures. Since the beginning, we established clear definitions for all variables. And for instance, postoperative complications are defined and recorded according to the esophageal complications consensus group and the more recent gastrectomy complications consensus group. Data are collected by the clinical leads of each unit, and we provide regular feedback information to participants. We establish since the beginning audits every 4 years. Here you can see this is at present, since we started, now there are 6 regions that has been integrated in the project with 49 hospitals. We have already collected data from nearly 5,000 patients. An important part of this registry is the feedback information provided by our data manager that provides regularly a feedback to each center, summarizing the missing variables and potential erroneous data to be checked by the principal local investigator. Our registry has provided all hospitals with benchmark information on 12 outcome parameters or indicators, as you can see here, are zero resections, overall complications, severe complications, reintervention, 90-day mortality, as compared to the average of the whole EURECCA group. And also we provide also a reference of other registries here, for instance, the DUCA. We also use, we provide this information using funnel plots with 95 confidence intervals around the Spanish EURECCA esophagogastric registry average, anonymous with regard to other hospitals. Concerning the transparency, that is very important in order to confirm the reliability of our data. Recently, we demonstrated after an audit that the EURECCA registry data are reliable, with a rate of completeness of almost 98% and accuracy of 95% after assessing a 20% of the cases included by each hospital randomly selected. Finally, and as an example of how we can use this information, we detected, for instance, that the rate of transfusion was very high, 42% in our patients. So we set up a multi-center quality improvement project assessing the implementation of the patient blood management program. And we were able to reduce the transfusion rate in our patients and also improve some other postoperative outcomes. For the future, we are planning to convert our registry into a website and also with a tool to provide instantaneous information to the clinical leads of all the hospitals integrated in the EURECCA project. Thank you.
Thank you very much, Manuel. We'll go straight on to Natalie Coburn with the data set and results from Canada and the US. Go ahead.
All right, thank you for inviting me to speak today. I've got quite a few databases to cover, so I just talk about the databases and not so much the data. I have nothing to disclose. Next slide. It's not forwarding through. So I'm going to start with some of the US databases first. I'm going to talk about the SEER database because really this is one of the gold standards that we consider for databases for cancer. This was actually established in 1973 by President Nixon. And when you think about this database, you have to understand its reason. It was to examine cancer incidence and then to examine survival. It actually only covers about 1/3 of the US population. That's up from about 20% when it was started. And it's based on state and local registries. This is really a gold standard in terms of data manuals. If you want to go look at how to create a data manual to set up your own database, everything's available online and quite fantastically explained. It can be combined with Medicare if you want to examine utilization and costs. Some of the downsides of this are based on the populations it draws from. It samples purposefully for unique characteristics like the state of Arizona for the native population, the city of Detroit and the city of Atlanta for inner city populations. Initially, this was really just coarse groupings of surgery, chemotherapy, or radiation. So if you want some more information about the type of radiation or the chemotherapeutics utilized, you won't find this. More recently, there is some more information regarding radiation, but chemotherapy is just single agent versus doublet or triplet. Historically, it had no data on margins, although that's been changed recently, and it does not look at QI issues, and you cannot get hospital level data from this. So building out of this, the NCDB was established, and this is established by the American Cancer Society and the American College of Surgeons. It's hospitals that are commissioned on cancer accredited facilities. So these are larger facilities, more stable facilities. It does cover about 70% of the cancer cases in the US. It's 34 million records, but it does not sample the smaller hospitals where one may imagine there's a bit more variation in care. The pros for this is very easy access if you belong to one of these hospitals. It establishes cancer quality indices and gives this information back to hospitals. So if you're looking for margins or lymph node harvest as a quality indicator, it gives your hospital this information. It gives very granular data on radiation, but it's not population based. I'm being told I'm very far behind. ICES is the Ontario Cancer Registry, or Ontario Cancer Data. It looks at outcomes. We have patient-reported outcomes within this data set, but we do not have TNM data. So to augment this, we actually went and abstracted pathology reports for 25,000 gastric and esophageal cancers. Obviously, this is pathologic, so YPTNM data and not clinical stage. Moving along to the quality, which is more closely related to the UK database that was discussed. This would be NSQIP from the United States and Canada. This looks at risk-adjusted complications, so 30-day follow-up of surgical cases. Again, this gives data back to the centers that belong. But as many of the other speakers have stated, there's no governmental support for this. It is costly to join. And so your hospital has to want to join and want to pay to join this. But the quality of the data that comes out of this is very good. And I believe the other groups have discussed the esophageal complications consensus group, which is an international group that Americans and Canadians both work through. And this creates benchmarks that we can all strive to achieve. So, whirlwind tour of the United States and Canada. I'd be happy to take questions at the end. Thank you.
Thank you very much, Natalie. The next speaker is Masayuki Watanabe, and he has recorded the presentation, so he will be the only one probably in time. So go ahead, we can play this and we'll talk to you after the presentations.
I'm going to talk about the current situation of the esophageal cancer registry in Japan. We have two registries, including the Comprehensive Registry of Esophageal Cancer in Japan, conducted by the Japan Esophageal Society, JES, and the National Clinical Database, NCD. The JES registry started in 1976. This registry targets the patients who underwent any treatment by the JES members. The data collection is retrospective, and the target year is 6 years before the registration. This registry is voluntary. The registration committee of the JES has collected the data. Since 2019, the registration method has changed from an electronic submission to a web-based data collection using the NCD system. Annual reports are delivered to the institutions, and the main results are published in the Esophagus, an official journal of the JES. Currently, we don't have an audit system in this registry. These are the representative results of the registry. We can provide the long-term outcomes of ER, chemotherapy or radiotherapy, and esophagectomy. Several research articles have been published using this registry data, such as lymph node metastasis and efficacy index in surgical cases, real-world outcomes of definitive CRT, and radiation dose and survival. These data contribute to improving the staging and guidelines. The NCD was established in 2011. Patients undergoing surgical operations in every Japanese hospital are registered into the NCD. Data collection is prospective. Because this registration to the NCD links to the board certification system by the Japan Surgical Society and the Japanese Society for Gastroenterological Surgery, the registration is mandatory. The NCD uses a web-based data collection system. Feedback is via publications as annual reports. On the website of the NCD, surgeons can look at their institutional results as observed expected ratios. Also, the NCD provides a risk calculator that can estimate the risk of mortality and morbidity. The NCD has annual audits, and the errors are corrected based on the results. There are several publications using the NCD data, such as the comparison between MIE and OE, risk of complications related to preoperative treatment and surgical approach, and the association between diabetes and complications. The JES registry has become to use the NCD platform since 2019. The participating institutes have been increasing, especially after 2019. The number of esophagectomy registration has also been growing, but remains approximately 60% of all cases. This is the summary of this presentation. The JES registry is retrospective, and the participant is mainly the JES members. The target is patients who underwent any treatment, and the primary outcomes are long-term survival and clinical pathologic figures, aiming to improve staging and guidelines. An audit has not been established. The NCD is prospective and collects all surgical cases in Japan. The main goals are surgical quality improvement and board certification. The NCD has an audit system. Thank you for your attention.
Thank you very much, Masayuki, for also a very good presentation. I'm going to take over from here. I'm going to also put the timer for myself. It's really difficult to tell what you want to tell in 5 minutes, because that was the thing we asked all our panelists, but I'm going to try to do that myself. So I chair the Dutch Upper GI Cancer Audit, the scientific committee. And our audit started in 2011, and since then it is already an obligatory surgical audit. So every patient has to be filled in. All patients undergoing a esophageal or gastric resection have to be put into the registry. So not for palliative patients, only for this group. The data is recorded by the hospitals and it's delivered to DUCA, the institute, through a data processor. And we aim to improve by benchmarking using this kind of funnel plot. We already saw this. And you have the different centers with your own center as a single spot. What is interesting that we use transparency of data to multiple stakeholders. And you can see these are the ones that are transparent: volume, participation in prompts, time to first treatment, but also mortality and postoperative complicated course. Internally, feedback is through a dashboard and also indicators that we think are important. Now, this is the dashboard I just mentioned, so you can look at your own results and have the national results there. So this is, for example, complications. You can see the national average and the number of complications in your center. And so this is all for all these data. You can put some limitations on there. For example, look at ASA 3 patients or look at female or male patients. And when you do this, you can also look at the trend, different trends that can be shown in the similar graphs. And I already saw them also from Nick. And you can see the trends in your center on complications, complicated course, or anastomotic leak. These are, again, this kind of funnel plot that we use to show different kinds of outcomes, for example, number of lymph nodes. And the thing is that all these fields have to be filled in, of course. These are the paragraphs, but over 200 fields have to be filled in. And we even added a few during the COVID time for extra COVID research. It takes around 30 to 45 minutes. But we now have arranged that, for example, the pathology report is automated. The fields are filled in by either PhD students, research nurse, or the surgeon himself, but the surgeon is really responsible for this. Here you can see again different graphs and different comparisons you can make through the audit. Some really fast results, because I already also went through the 5-minute limit. What we see in the audit, if you compare the first and the last years, that in general, patients have a higher risk profile undergoing surgery. So we have older patients, higher BMI, and more ASA plus patients. What we also see that more patients have neoadjuvant therapy. There's an increase in the use of diagnostics, and we use more transthoracic surgery and more minimally invasive surgery, and also more intrathoracic anastomosis. This resulted in a number of improvements, for example, more resected lymph nodes, a higher R0 resection rate, and also a lower futile surgery rate. That is real improvement. Also improved were hospital stay, 30-day mortality. This is all for esophageal cancer. There are similar data for gastric cancer, but what we do see that still a high percentage of patients has complications. So there's still a lot of work to be done. And we look at it through, of course, also a scientific eye. These are the publications we had in 2020 and 2021. And I'm convinced that with this, we can really improve our national results even more. Thank you very much. So I would like to ask to have all the panelists turn their cameras on so we can have a short discussion on this. Let me see, whom can I just give a short word, not too long, but just some comments. I think I saw a few interesting things. Maybe Shiraz, you just logged in just in time to see our presentations.
I did, thank you, Mark. Great.
Do you have some comments on what you saw, or?
Yeah, absolutely. I mean, I think one of the things that I think is interesting is the process of validation of these registries, and I just wonder, Natalie, it's one of the things that in Europe we've stressed quite a lot about how the registries have to be validated in order to provide meaningful data. How valid do you think the processes are in North America for ensuring the accuracy of the data you're collecting? I know in Ontario, obviously it's slightly different, but across the sort of SEER data set, NCDB, these kind of data sets, what do you think?
I think it's variable by the data set. I think SEER is very well monitored, and the data abstractors are very well trained, and it's governmentally supported. So unlike some of the other ones that were mentioned, SEER is governmentally supported. It's centrally supported by the state or the local cancer registries. There's a tremendous amount of training that goes into those people who are entering data. I think when you come down to NSQIP, it's very well supported, but it costs a lot of money. Your hospital has to be very interested in doing that. And so it's not all hospitals. And so when you look at a NSQIP publication, you have to understand that those are self-selected hospitals that are looking at quality. When you look at something like a local database where you have students or nurses or rotating team members who are entering data, and certainly I'm part of a lot of those databases, sometimes the data is variable, and sometimes you can come up with some very, very bad data entry problems because people that's simply not their full-time job. If you have a full-time job entering data, the data quality is going to be much better. But again, it comes back to what every speaker raised, that costs money.
Yeah, I think that is really a very good point, I think. And maybe if we look at Japan, Masayuki, could you help us and tell us a bit more about the audit? What do you think could be better when you have it? For example, is it possible to have an obligatory audit? Is that something that would be possible, or is it just not possible for Japan?
Actually, Japanese Association for Gastroenterological Surgery do the audit for the gastroenterological area of the NCD. So recently, they do the remote audit using the website or something. So the cost is going down using the website, but anyway, the money is a problem. The JS registry has not audits because of the shortness of the budget. So yeah. I think that's a very important point.
Yeah, I agree. I see Jan has a question or a point, maybe. Jan, go ahead. Your hand is raised, or is it?
Yeah, I'm sorry. I didn't. No, I have nothing to discuss. I'll just put it on.
I think the point of the financials is really important. Manuel, how did you solve it in Spain?
Well, in Spain, as I said, we started just in the first region, Catalonia, where centralization took place, and we are expanding to other regions. But the problem is how we obtain economical support for our project. At present, there is no support from the government or surgical societies, but we are working on that because just maintaining data managers and the whole structure is very expensive. So this is a big problem.
Yeah. And Nick, can you add something for the UK?
Yeah, I mean, we're as I said, we're funded by the NHS. But if you're not one of the chosen national cancer audits, then there is no public funding at all. So we're very lucky with esophagogastric, but the other tumours we deal with in August, liver, pancreas, there's no funding at all. And although we're just about to get pancreas on board, I think. So we are fortunate to have that funding, but equally well, it means it's very difficult to change anything about it. So the initial contract was to look at epithelial tumours only, so we cannot use the audit to collect any data on any other types of cancers of the esophagus and the stomach. So it's quite a bureaucratic thing to go through if you want to make any changes. And when we last year, well, 3-4 years ago, when we introduced new outcome fields such as details about margins and lymph nodes, it was a really laborious process to get that adopted. And the final comment is that it is funded, but we have to apply for refunding every 3 to 5 years. And there's always that uncertainty built into it.
Yeah. What is also interesting that in different audits, it's also different kind of patients that are there. So also palliative care patients. I think I saw it in the UK, but also in Sweden that they're in the registry. In Holland, for now, unfortunately, it's only the patients intent of undergoing a resection. So no palliative patients in there yet. So I hope that will change in the future. But that's also something that is of course very interesting. Manuel, I think we have to go on. Can you take it from here?
Yeah, okay. Thank you, Mark. And then we will continue after these very interesting short presentations where we have seen all the differences between the registries. And then we will go on with the next presentation.